This is an interesting one on COVID reservoirs in long COVID patients, where it's been found that some individuals with long COVID do not fully clear the virus after their acute infection. Instead, there's replicating COVID virus and or viral RNA, so two different things happening there, that are potentially capable of both producing viral proteins and persisting in the tissue as a reservoir, which could then relate to the immune exhaustion that we're seeing in some patients, in addition to some of the long COVID pathologies such as coagulation, the microbiome alterations, the neuroimmune abnormalities, and etc. Where current estimates in the US place the burden of long COVID at about $743 billion per year, including a reduced quality of life, lost earnings for the individual, and increased medical spending. And when we review the literature, there are autopsies that have been performed that have shown COVID RNA and proteins in dozens of body tissues, including the brain, where over half of the cases had persistent RNA in the lymph nodes from the head and neck, from the thorax, the sciatic nerve, ocular tissues of the eyes, and regions of the central nervous system, including the cervical spinal cord and the brainstem and the olfactory nerve. So these would all be potential reservoirs, and other studies have shown that in 80% of lung tissue samples from COVID-infected individuals, there's still persistent reservoirs as well. With the wild thing being that COVID RNA or protein has been identified in tissue months after initial illness, despite negative results via standard nasopharyngeal PCR testing and or the lack of detection in the peripheral blood from the same individual. So even if you aren't testing on our standard tests, you could still have this viral persistence in your body. From a tissue biopsy study in people with inflammatory bowel disease, they found that for mild acute infections of COVID, about 70% of participants harbored COVID RNA in intestinal mucosal tissue, so a reservoir in the gut as well. And this viral RNA was unrelated to the severity of the acute infection, where another team detected COVID RNA and spike proteins in the colorectal tissue up to 676 days following the initial COVID illness. So for a very long time, these reservoirs can persist. Other studies have shown that COVID RNA has been found in the skin, as well as the appendix and breast tissue. And this is up to 426 days after the acute infection with COVID. In addition to the olfactory mucosa, so in the nasal passageways, up to 196 days after symptom onset. And notably, a subset of control patients who reported full recovery after COVID infection also had detectable viral protein in their plasma, so even if you feel okay, you can still have this happening. Additionally, for long COVID patients, their blood plasma still had COVID in the plasma itself, which may indicate harboring replicating virus. And the interesting note is that even if you don't detect these COVID proteins or viral RNA within the blood plasma, it could just mean that your specific viral reservoir is in a site where these viral proteins are less likely to reach the blood circulation, your peripheral blood. So in that case, think of things like in your brain. And even more interestingly, they found that this ebbs and flows in long COVID patients, where spike protein was identified in plasma of the same individual at some time points, but not in others, indicating that COVID reservoirs could have periods of inactivity and then resume protein production and replication at other times, such as when immunocontrol is altered. And these COVID reservoirs, specifically in the gut, so the gastrointestinal tract or the oral cavities, can be accompanied by low-grade local inflammation and gut microbiome dysbiosis, where this local inflammation makes it easier for COVID to pass into the bloodstream by expanding the barrier, making it easier for things to pass back and forth along it, which sort of creates a perpetual process where the COVID can continually enter the bloodstream and go elsewhere and cause additional issues throughout a long period of time, since the viral reservoir in the gut is not being dealt with, the intestines. So ultimately, for all of this, the authors believe that some forms of antiviral treatment may only show benefit during active replication of COVID, So it's possible that a single course of the COVID antivirals like Paxlovid is not adequate to fully address viral persistence in relevant long COVID cases, and that even for acute infection, the viral rebound after treatment due to incomplete viral clearance is well documented. Therefore, treatment of COVID reservoirs in long COVID may require longer dosing periods to achieve maximum efficacy. And that some treatments need to be tailored so that we can address these secondary effects, like for multi-inflammatory syndrome in children using larizotide to restore gut epithelial barrier permeability, um, preventing COVID from being able to transmit into the bloodstream as efficiently. So, doing something like that in tandem with the antivirals to enhance their effectiveness.